This is Jenna Hopkins with my Living with Long COVID series. This is a very ambitious video, so I'm going to be going quickly. It's especially important that you understand that this is the fourth in our series. If you have not already been screened for post-exertional malaise, hypermobility and EDS, mast cell disorders, then you should not be watching this dysautonomia video yet. You need to take care of all of those things prior to watching this, and I will kind of be letting you into why. My Tin Man is related to the heart, so we are going to be talking about dysautonomia and heart conditions. I did want to go through right away, though, is that we're mainly going to be focusing on dysautonomia. Anything that is a true heart condition needs to be managed by cardiology or by your primary care physician. If you have any new onset symptoms that mimic these red flag symptoms over here, this is an emergency situation and you need to get to the emergency room. So that's going to be chest pain on exertion, syncope on exertion, that's lightheadedness, dizziness, feeling faint, acute and progressive dyspnea, tachycardia at rest or on minimal exertion. So really feeling that shortness of breath or that your tachycardia is very high. If your blood oxygen is less than 94% at rest, you feel confused, your symptoms seem like a stroke, or if you have thoughts of self-harm or worsening anxiety or depression, please, these are serious and urgent symptoms. You need to contact your doctor or go into the emergency room, especially if you have not been screened. If your doctor has told you not to get checked out, if you have something similar to this because that's typical, normal for you, or you've already been screened, that's between you and your doctor. Otherwise, those are red flag symptoms. Cardiovascular risks are associated with long COVID. This is even in somebody who has a low risk of cardiovascular disease. Even beyond the month after catching COVID, there's an increased risk in cerebrovascular disorders, dysrhythmias, heart disease, pericarditis, myocarditis, heart failure. The risks of this are evident regardless of age, race, sex, or cardiovascular risk factors like obesity, hypertension, diabetes, chronic kidney disease, and hyperlipidemia. So what I'm trying to tell you here is that even if you don't have a pre-existing heart condition, nothing wrong with you, if you get COVID, then you are at increased risk for stroke, heart attack, and heart issues for we don't know how long. It's more than a month. We know that for sure. So these risks are present in individuals who may not have been hospitalized because of COVID, and it's different severity. So some people, even after not even having symptomatic COVID, then they were still at this heightened risk. So every time COVID goes through down, basically I say the risk of heart attacks and heart issues goes up. So I do want to make sure you know you're not dealing with heart attack symptoms here. These are going to vary from person to person. They're not always sudden and they're not always intense. Common symptoms are chest discomfort, so pressure, tightness, fullness, or pain or discomfort in other areas of the body, one or both arms, back, neck, jaw, or stomach, shortness of breath, feeling breathless, cold sweat, nausea, lightheadedness. And then women especially seem to have just fatigue or indigestion. So you really need to get to see the doctor if you haven't been screened for any kind of heart condition. I also wanted to put stroke symptoms in here as well because the risk of clotting issues is worsened by COVID as well. So that's going to be fast. If your face droops, your arm is weak, your speech is different, then it is time to call emergency services. So other common symptoms include sun numbness or weakness, severe headache, dizziness, lots of balance, trouble seeing in one or both eyes. The sooner a stroke is diagnosed and treated, the better the chances are of recovery. Get into your emergency room now. Do not lay down and take a nap and hope those symptoms go away. Again, some of these symptoms are very common for long COVID. So this is if you have not been checked out by your doctor already and come to terms with what constitutes an emergency for you. So mostly what we're going to be talking about in this section is going to be those dysautonomia symptoms. And this does affect your blood pressure and your heart rate. It also has systemic effects. Dysautonomia is autonomic nervous system dysfunction, and that's where your fight or flight and your rest and digest systems, that's sympathetic for fight and flight and parasympathetic rest and digest, are no longer working together. So one of the most common features is that you have orthostatic intolerance, and that's that your blood pressure or your heart rate changes when you are standing. POTS, postural orthostatic tachycardia syndrome, is the most common type, but that is not the only kind. About 60% of people with long COVID are estimated to have some type of dysautonomia, and we know that COVID triggers POTS. But we have to know that there's different stages of dysautonomia, and it can improve and worsen over time. So we need to manage dysautonomia symptoms really quickly and really well. There was a great article out of the Washington Post. This was very recent, April 10th, 2024. And basically with this article, they're talking about how exercise might actually increase the risk of developing POTS post-COVID. Because young athletes are really developing this frequently. So it says before 2020, 1 million to 3 million people total suffered from POTS in the United States. Precise numbers are difficult to come by because of the condition encompasses a spectrum of symptoms, and some people still haven't heard of it, i.e. it was hard to diagnose before. But now 2 to 14% of people infected with the coronavirus may go on to develop POTS. What do we know? They are probably still undiagnosed, because if your symptoms are not bad, then you may not get that the information from the doctor, because maybe your doctor still doesn't know that much about it. So I really feel like it's still underdiagnosed, or people are given diagnoses of like anxiety or things like that because your heart rate's going up. So you seem anxious. What do we know about long COVID is that why do we think it's happening? We've got immune system dysregulation. We've got gut issues and microbiome changes. We've got autoimmune conditions, we've got blood clotting, we've got endothelial abnormalities, and then we have dysfunctional neurological signaling. So that's dysfunctional signaling in the brainstem and or vagus nerve. Why am I bringing that up? Because what we see is that there are multiple triggers of dysautonomia, and many of them are tied into those causes that we just talked about. So over here, we've got autoimmune issues, and that includes mast cell activation syndrome, which is often correlated with gut dysfunction. We have trauma, which if we've got that dysfunctional vagus nerve, then that might be actually a physical issue. I think, and I have not seen as much research about this as I would like, but that nutritional deficiencies are going to be linked to severity of long COVID symptoms. We already know that low iron is linked to POTS. We already know that vitamin D deficiency is linked to worse acute COVID. So, that's something else to take into consideration. B12 is another really big one. We have an increase in thyroid disorders and diabetes post-COVID. We know that people that are pregnant are at increased risk of long COVID. We've got down here, this might explain some of the people that are vax injured, especially if, it's not a spike protein issue. Then we have the excessive training, overtraining syndrome, and bed rest. So a lot of times, initially people were like, oh, you're getting dysautonomia because, you laid down for a week after you had acute COVID and that caused your dysautonomia. And that is not true. As we just saw in that Washington Post article, I actually think it's more shifted to this, where the people I see are very active and actually overdoing it, and they're running their body out of resources. And then we also have that people with Ehlers-Danlos are at increased risk for long COVID, and some of that I believe is physical. So I'm going to be talking about the TMJ a little bit, the CCI a little bit in this, but just so you know, all of these things can trigger. So if any of these are on the list for you as potential things for you to manage better, that can help with your long COVID symptoms. Getting just right activity, managing thyroid issues, managing your diabetes. If you've got TMJ, you've got to manage that. If you've got neck issues, you have to manage those. So again, some things are going to be related to these structural issues. I have so many people that are clenching and that have TMD or temporomandibular disorders. When the jaw is not aligned, it aggravates the trigeminal nerve. And this is basically the counterbalance to the vagus nerve. So when it's overstimulated, it basically, like your car, is all accelerator and no brake. So it's supposed to be that they're working together, but that is not the case. Neck issues and neck tension, especially the cervical spine, is going to be a big one too. So if you are too tight, doing frequent neck stretches and things like that is great, but people confuse tightness and pain. So all you people that are hypermobile, please don't be doing a whole bunch of crazy neck things or going to your chiropractor, because that can actually worsen the issue sometimes. Okay, so don't forget dysautonomia, that is tied to other things. So sometimes vision issues, dry eye, light sensitivity, digestive issues, especially constipation. And then, of course, that history of fainting or feeling lightheaded. I included a QR code which has the Compass 31 attached. This test goes over symptoms of dysautonomia. This is a really good test to take into a primary care doctor if you want to go to a dysautonomia specialist. And other tests that those dysautonomia specialists can do is basically the Valsalva maneuver, the deep breathing test, the Q-sweat, and then a skin biopsy for small fiber neuropathy. The other thing that you can do is an active stand test, or if you've heard of the poor man tilt table test. So this has the instructions for how to perform it. It takes just over 15 minutes to perform. So you are going to lay down for 5 minutes with your legs uncrossed. You'll take blood pressure and heart rate. You have to use a blood pressure cuff on the upper arm, and then you stand absolutely still. The blood pressure gets taken 3 minutes, 5 minutes, 7 minutes, 10 minutes. You're not supposed to talk except to describe the symptoms as you feel them. If you are very symptomatic and cannot stand safely, then you need to perform this with a healthcare professional, or be like, hey, I really need a tilt table test instead. This can basically be used to diagnose a few different autonomic disorders. POTS is one of them. So over here, it shows you that heart rate increases of equal to or greater than 30 beats per minute within that 10-minute mark for adults, or 40 for adolescents. That is diagnostic of POTS, but there's a few other things in here, and that includes exclusions. We need to make sure you're not dehydrated, that it's not because of your meds. And most of the time it's that this has to have been going on for greater than 6 months. We've got a few other options here: neurocardiogenic syncope. Those are the people that pass out. We've got orthostatic hypotension, and that's a drop in blood pressure. And then we've got inappropriate sinus tachycardia, IST. And sometimes people will basically qualify for one of these, and then sometimes they get diagnosed with another one later, because they are all under that same umbrella. Stay tuned for part 2.